Our final speakers in this stream on home care today are Alan Long, the Executive Director of Mears Group, and Sue Redmond, her official title is Interim Director of Adult Care for the Tri-Borough. Now, everybody looks a bit blank when we say that. We've just discussed it, which is the Tri-Borough was formerly known as Hammersmith and Fulham, Kensington and Chelsea, and Westminster councils. And we've had Adapt and Die already, and we were hearing about the need for radical reinvention. I think now we're moving on to radical adaptation, in that we are going to be talking about outcome-based commissioning. And we're also going to be drawing on Sue's previous experience as Corporate Director at Wiltshire Borough Council as well.
Thank you very much on two behalves, really. Thank you for coming along this afternoon, and particularly staying as long as you have during the day. So we're quite a nice build on the last presentation, those of you here, because we are very much going to be talking about adapting and finding a solution to really the big issues that are in social care and in health care today. Sue is very much the main speaker. I'm the warm-up act, because Sue is actually a real practitioner, has led, I think, in a highly innovative way, together with her team, in creating a completely different model of delivering care, which is very much outcome-based. Who am I and who are Mears? Well, outcome-based commissioning is very much close to my heart, simply because of what Mears does. Mears delivers two types of services. It delivers housing services to social housing, repairs and maintenance services, and contracts from social landlords have been outcome-based. Public sector commissioned contracts have been outcome-based for many, many years, and have made an enormous difference to the quality of services delivered through housing. We're also a domiciliary care provider and a home improvement agency provider, and it's quite shocking to me to see the difference in commissioning practices between the areas, and I see enormous opportunities to improve quality and to reduce long-term cost by adapting an outcome-based approach to commissioning with health and social care, and I'm really optimistic about the improvements in service that can bring. And Sue's going to take us through a real-life experience of that from Wiltshire. What Mears did together with the local government information unit, and I'd encourage you, if you haven't got this particular report, Outcome Matters Effective Commission, then please try and get a copy. There's a few copies left at the back of the room here, and there's a few on the Mears stand as well. What Outcomes Matter Effective Commissioning attempted to do, firstly, it was a consultation exercise, and basically asked a load of local authorities, 113 councils, do you do outcome-based commissioning at the moment? The responses suggested that a lot didn't actually understand what outcome-based commissioning was, to be frank, but we did hear two things which were quite interesting. 75% of councils said the current system, which is all task and time, i.e. providers are paid for just turning up, how many minutes they work, doesn't matter whether they do a good job or a bad job, you get paid the same. 75% said actually they didn't think that was a very good idea, but actually 90% said that's exactly what they do. And I suspect 90% is an underestimate of the reality. And 13% they actually said they pay by the minute, so probably the worst example of task and time. The report you can read yourself, but I guess the highlights that came back, because this was followed up by a series of roadshows where over 60 local authorities came and attended some round tables to put some meat on the bones of the report. These are some of the main findings from that, really, that local authorities generally valued the idea of outcome-based commissioning. I should say there are outcomes when I talk outcomes, I mean there's outcomes for individuals, which are becoming more common in terms of design, but also as importantly, outcomes for communities and commissioners, which are often around reducing residential care admissions, speeding up hospital discharge, and actually avoidance of hospital admissions to start off with, as well as building a vibrant care community, sustainable community of care workers. So the concept was valued, but actually task and time was recognised by commissioners as actually one of the things that's leading to current problems, which was great. And I guess a key thing to pick up here about task and time is it breeds a culture of dependency among service users. So if you're only paid to turn up, where is really the incentive upon the provider to work closely with the individual to actually help them do things they could do themselves, to make them less dependent on the care service. And Task and Time discourages incentivisation, investing from people like Mears in services and care quality that actually reduces dependency, enables people to do more things themselves. From a commissioner's perspective, for me, it's like going into a cul-de-sac. You get to the point where if all you're doing is trying to reduce the hourly rate, given now pressures of minimum wage and where the market is going, the alternative job opportunities available for people, the Task and Time-based commissioning structure is a cul-de-sac in terms of developing a sustainable workforce. And we're starting to see, you'll all be aware, some huge cracks in the system relating to that. I said defining outcomes is difficult, but it's possible, as Sue will doubtless demonstrate. And most importantly, if you're going to create that, you've got to create some level of trust with your providers you're working with. You've got to have the processes to build that trust. So what do I believe in? I believe quality is the best way to reduce long-term cost. It's a wonderful combination that actually improving the quality of the service is the best way to reduce cost in the system. And that is an obvious thing to say, but it's so seldom recognised in the way services are commissioned. I would encourage providers to commission for delivery of outcomes, not minutes, reward quality of care that reduces really high expense things that people generally don't want. And people don't generally want to go into hospitals, people don't generally want to go into care homes. Let's get over the silo-based commissioning that exists. Why is it that people commission products, not services? So we'll commission some domiciliary care, we'll commission some telecare, we'll commission some community equipment. Why don't we commission an independent living service and let providers sort out amongst themselves how they work together to deliver an effective integrated service around the individual? Why doesn't that happen? As providers, Mears included, we've got to accept that if we do a poor job, we get paid less for it, and we've got to take risk around that. So we've got to put our money where our mouth is, our service where our mouth is, and be paid well if we deliver quality, be paid badly if we don't. And finally, create the choice that service users want, not what is forced upon them. Choice has been misinterpreted in my view. Choice in some areas has been we need to get as many providers doing exactly the same thing in a particular locality. Service users don't want that. They want choice of a few quality providers and a flexible service that opens up options to them to achieve what they want in life. And I'm sorry to say that choice has been completely misinterpreted from a customer perspective in my view. So I'll hand over to Sue. I agree with the last presenter, the system needs fundamental change. I think outcome-based commissioning is the key to this, and I think stronger partnership working is the means to deliver that. Thank you, Sue.
Thanks. Hello everyone, it's noisy in here, isn't it? Got bottles on one side and someone else speaking on the other, so I hope you can hear me. Alan was talking about my last job, which was over 6 years in Wiltshire, which I've recently just left, where we led on trying to do something differently. And if I can just talk us through what we actually tried, and it's still in its infancy, you know, it's not perfect, but it's just about trying something different. And in terms of what we thought about, our hypothesis was that commissioners are responsible for the care that we get. And all the attacks on providers, you know, some providers aren't very good, but it's how we commission and the responsibility we take as commissioners, which is key to the quality of care that we get in our areas. And we need to get real about that, I think. And yet we're all under budget constraints, we're all under terrible pressures, but we can think of things differently and we can try and do things differently. So the way we commission does create dependency. If we do it by hours, people need more care, we commission more hours, and it goes on and on and on. The way we commission can also lead to, not always, and it's amazing how in spite of sometimes how we commission and how we negotiate with providers and how we treat providers sometimes, it's amazing how great services are. But the way we commission can lead to poor recruitment. We don't pay commissioners enough to recruit or to train or to provide proper terms and conditions sometimes. And this can cause poor outcomes. And if you've ever done a day or a week or a few weeks, as I have as a home carer, you'll know that the processes, the rotas, the paperwork, it's horrendous. And this can cause, poor care can cause bad outcomes, and then inevitably that increases need, which then increases demand and increased cost. And I'll explain that a bit more about how it actually worked in Wiltshire for us. And you all know what people say, and Alan said this as well. People say, and we surveyed, as you all do, hundreds and thousands of people who are in the service now, but people who are going to be needing to be in the service. No one wants to need long-term care. What people want to do is stay at home and live their lives. If they do have a crisis, they want help quickly. They don't need a whole myriad of choice. And actually, certainly in Wiltshire, people were saying to us, please don't give me loads of choice. That's not actually what's going to work for me. I want the right service at the right time. And if it's a good service and I know it's a good, that's what I want. And it's about what happens in my home rather than the number of providers I can choose from. They wanted help with the problem they told us about, not what the problems we define for them, because we suck people into our system in the whole, and then when we get them in our system, we define them in terms of the categories we have, and we give them services as per our menu, and that's not what people want. They want flexibility, proportional assessments. They want to be treated as individuals and to be heard, and organise our services so that people can understand them. And also, interestingly enough, in some areas where there are a lot of people who fund their own care, people are saying they want the same offer, same good quality, the same services that have integrity that anyone else would, and they want a fair offer for people who use the public purse for services as well as pay. And that's good for everybody, because we don't want several levels of services for people who can't afford to pay. We want a great service for everybody. The experience in Wiltshire at the time was we all forecast our budgets, and our costs were growing faster than we forecast. It wasn't about demography. We all say, oh, we've got demographic demand, we need more money, we need more costs because we're having more older people coming through. It was beyond that our costs were increasing. And we looked into care packages, and when we commission services, one of the things I've learned over the last years is we really do need to get some economics in our commissioning and understanding our market and our business. Our care packages grew 1 hour a week for everyone who was in the service over a period of 3 years. That meant that people who we got into the system stayed into the system, and we helped them get more care. We helped them become more dependent over those years. It wasn't that we were looking after people with more high dependency needs, which is what we all thought anecdotally. It wasn't that. It was people staying in our system forever and increasingly becoming dependent. Now, you might say that's inevitable. People go old and they get failure, but that's not inevitable. It was the way we commissioned and the way we reviewed. Sorry for the jargon. Delayed transfers of care from hospital were hard to manage because we didn't have the agencies who perhaps could take people from hospital who really needed complex needs, etc., etc. We spent more on older people's budget, and we were spending more on care homes. So often as commissioners, what we do is look at the home care budget bottom line, separate from the residential nursing care bottom line. We need to look at the bottom line of what we spend for everyone. The contracts were coming to an end. We had loads of them. We didn't actually manage them. We didn't actually review them. Our contract workers worked their socks off, but they didn't really know the quality that was going on around. And so we weren't really contract managing, and they cost more than they should do. And for me, really importantly, we didn't have good relationships with the providers, the very people who knew our customers best, because we thought we knew our customers best. We didn't have good relationships with them. We were arm's length. We didn't treat them as partners. Sometimes our assessment people weren't very good with them. The relationships were bad, and that isn't good for our people who need care. So what is Help to Live at Home? Well, it's a new service. So what we needed to do from all that is basically chuck out everything we've been doing and design something new around the person. So we came back to what do people want and how can we design a new service for the people that we're supposed to be working for, not in terms of how we had traditionally done things. So we started again. It was an integrated service, so it wasn't just... The whole service is about reablement, if I can say that. It's about promoting independence. It isn't having one bit that's reablement and another bit that's maintenance home care. So it's about, we integrated reablement, personal care, housing support, community support equipment, etc. You'll see on the slide. The lead member who championed this, because it was really important the politicians championed it, said there's so many footsteps up the footpath, no one knows who's doing what, and no one's talking with each other. You know that conversation that we have about integration. It was that. It has clear responsibilities for all of us in this system. So the council, and I'll explain how it works in a minute, but there's clear responsibilities. So we know very much that the council is responsible for managing and reviewing and assessing. Providers are responsible for reviewing, doing a support plan, and customers are responsible for designing that support plan with the providers, and actually for accepting that a service isn't forever that comes into their home. It's absolutely time limited. It links customers' outcomes to providers' revenues. So it's about paying for results, basically. It takes a different view to personalisation. The personalisation that really matters is what happens in someone's own home and what control they have over what happens to them as an individual. So, for me, it doesn't really matter about RASs and everything else that goes on in the world of adult social care. It makes care and support affordable as much as we can do, and I'll come on to that, by promoting independence. It's all about promoting independence, whatever stage people are at. There's no means test for the first few weeks, as there isn't in many authorities. But we want as many people as possible to come through that first few weeks, including self-funders. Everyone should come through that. No one will get a direct payment. No one will go to residential care when this works out properly. Everyone has to come through this before direct payments, etc., are decided. And there's a whole system process managed by the council's IT systems. So we share IT systems with the providers. We send all the data and we share the Carefare system. So it's open and we share things together. So it's moving from hours to outcomes. And this chart just gives you a little picture. What happens, the top line is people coming into our system in a crisis. And what we generally do is there's a lot of care goes into someone when they're in a crisis, and we keep it there until we review. Sometimes we might not review for ages, months, a year. People are having that care whether their needs go down or not, and often people's needs do go down. So there's an opportunity cost there, and there's a waste of money that we're doing for those people, and we're doing it time and time again. And we worked out how much that might be in Wiltshire going forward, and it's considerable. We changed that to a model that was based on outcomes. So if someone comes into the system, I'm trying to go very quickly. If someone comes into the system, and I'll explain the outcomes in a minute, they have a very clear, short initial support plan, which they agree with the providers, which is very short and time limited, 2 to 6 weeks. They're reviewed, and the outcomes, we assess the outcomes. If the outcomes have been met in full, the provider gets some money. If another set of outcomes are needed to be discussed with the person, that discussion is had again, a new set of outcomes are defined and then measured, and the provider is measured on those outcomes. And whatever stage anybody is, even in end of life, someone can have an outcome that matters to them that they want in terms of a goal. So we're not accepting that reablement is only for a few people. This is about maintaining independence, helping people meet the goals that they have, whatever stage of life they're at. Payment by results. We spent a long time on how to work this out, and we spent 18 months, 2 years working with a whole range of providers and a whole range of older people working how this would work out. And it isn't working perfectly yet, but it's starting. And outcomes you have to be able to tell they've happened, and you have to be able to observe them. So back at the ranch, the social workers or the care managers have to know that person's outcomes have been met. So they have to be obvious, and they have to be clear. They have to be attributable to the provider. So it was something the provider did that made that achieved that outcome. Nothing. So it was absolutely attributable to them, so we could pay them. And they have to be very clearly defined. And I'll show you some list of outcomes in a minute. There's a whole range. There's about 30 different outcomes that we can explore. And it is payment by results, but the budget is set on the results being achieved. It's not about penalties, it's not about screwing providers, it's not about negotiating down and saving money. It's about saying, we want these outcomes to be met. We want the providers to get the money that we've agreed with them from the outset. So when we do an initial support plan, the providers talk to the individual about their initial support plan. They have the outcomes that we've discussed with the individual, and they work with the individual on how in the next 6 weeks they're going to meet those goals. If they don't meet those goals, no one wins. The customers don't win because they don't get what they wanted. The council pays more in a way because the goals aren't met because we have to do something else, and the provider loses costs. So it's not about payment by results. Isn't about penalties. It's about really incentivising, hopefully, our providers to work in a different way. Now, I suppose the scale of that change we didn't really grasp. The scale of that change, moving task and time and hours to this different approach, which is around the person, a whole person approach in terms of their goals. We did underestimate probably the scale of that change. So now, as a result of this, the whole premise of working is about strategic partnership with providers. It's 7-year contracts. It's saying to them, we're in this together. Let's work together and try and sort these issues out. We're all in this together. So it's a different arrangement, contracting and commissioning providers. So we buy fixed price support plans from the provider. They work out how that support plan is delivered with the individual. At the end of the plan, the providers tell us what's happened. We check with the customer, so we do the review and see if the outcomes have been met. If the outcomes haven't been met, there are a range of penalties. But it's only if the outcomes haven't been met and that's attributable to the provider. If something else has happened, that doesn't happen. If the provider delivers in less time or less than the agreed price, we don't quibble. We pay them. They keep that money. The idea being, one of the key of this is about promoting independence, and it's saying to providers, can you work in a totally different way? You can work that support plan out however you want with that individual, and if you want to take that individual, well, we want to encourage you to work with that individual to live in their own communities. So engage them, help them to go to Age UK Lunch Club, help them to go to their local community. If you can do all that in less time, and that means they've engaged with their communities, and they're not stuck at home. Because home, let's face it, care at home is equally lonely, and they're not stuck at home, or they have another support group that comes in. You can do that. We want you to do that. Actually, we would encourage you to do that. And the more you do that, you don't spend as much money, and we'll still give you the support plan amount that we've agreed. So they can keep the excess, and that's what we want to encourage, that whole connection with communities. There's a whole range of outcomes, and they're very specific, and these aren't, as rocket science, but the way people do it can be different. And what we've got is a support plan, which is not rocket science, honestly, it's very simple. But a provider wrote the support plan, which is how to help Bob with his meals. And it's just different than we normally do things. I'm not going to dwell on that because, it's not rocket science. And that's all I wanted to say, but I really did want to say that it's new. It's a new way of working. It's working with providers differently. It's trusting them. And instead of us having an industry as commissioners on e-monitoring and contract managing and reviews that we don't actually deliver, this is about sharing with providers, and it's shaping it around the person. And it's beginning to work, but there's a long way to go.
I'm sure there are going to be questions, because it's very refreshing to hear from a commissioner talk like this. Questions? I'm sure there's going to be one. There is indeed. And it's near reach of the microphone as well, which makes a change. Here we go.
Sue, can I ask you a question?
Sue, sorry.
I'm over here.
At the back. You won't be able to see it.
When can you come to the Royal Borough of Windsor and Maidenhead and bring this leadership with you?
I think I went to Windsor and Maidenhead, and James and I went, and we explained all this to your senior management team.
Come back and do it again. It's a request. You might want to stay up there for a bit. I suspect there'll be more. We've got one at the front here, and if anybody else at the back, and then a lady over here. So one, and then two there, and then I'll peer at you all again.
It's not working, that one.
No, it's not.
David Hogarth, Westminster Health+. You said, I think at the beginning, that measuring the success in achieving the outcomes is difficult but challenging. It seems to me that if you throw electronic monitoring out of the window, it's going to be extremely difficult to measure these things. And in the present state of affairs in London, I would say that people would simply take advantage of it and probably spend as little time as possible, and they wouldn't care much if the outcomes were delivered or not.
Well, both. Do you want to go first, and I'll give you.
Did anyone hear that? It was about e-monitoring. Different councils are different positions, and I work in the council that you're talking about, and I do know the issues. And I think it's a phased approach. I'm not saying throw e-monitoring out the window, but if we think what e-monitoring was about, it's about making sure providers turn up on the times that we have allocated for them. And if you're doing something different, which is this is the whole process change that we're doing. So the whole process change ensures quality and reviewing outcomes in a different way. So it's not about saying that if you've got a thing now which is time and task, and if you've got an environment in which you really need to check up on providers and et cetera, well, okay, e-monitoring has a purpose, and I'm not saying not have it. But if you're changing the system around and totally turning it on its head, well, there's a less role for e-monitoring, because I'm not saying this happens there, but what happens in a lot of boroughs is we spend a lot on e-monitoring. What do we actually do with that? We then go back to the provider and say, you didn't turn up at 9 o'clock or 8 o'clock or whatever. And it's a totally different relationship we've got. So I'm not saying throw it out the window. There's steps that we need to get to this, and boroughs are in different places.
And I just add to that, it's kind of if it's in an outcome-based system, you provide the elements of a system to deliver that outcome. So if the outcomes a service user wants require the use of electronic monitoring, then we would use the electronic monitoring. But to have it in as well, just because we don't trust the providers to turn up, then forget. You shouldn't even bother trying to do outcome-based commissioning, because you're in the wrong place as a commissioner. You're saying you don't trust the providers, so this system wouldn't work. So I'd recommend you don't do outcome-based commissioning if that's your starting point.
There was a question for the lady in the middle there. Yeah. Just about to see you.
Yeah, I think it's a related question in the sense of it's about providers actually and how happy they are. And I'm assuming that you probably commission and procure services from groups of providers working together sometimes, maybe some specialist providers and some larger ones. I might be wrong. And I'm just wondering whether your sort of smaller specialist providers ever feel as though they're being excluded from any process at all. What I'm thinking of is, I don't know if you've come across the lead provider model, where large organisations, large providers get together with smaller specialist ones. But I know that in the work programme, for example, that's been criticised by the smaller ones for being so-called bid candy. And I just wondered if you do ever commission or procure from groups of organisations. Can I
just respond quickly first, and I'll hand over to Sue. I don't think there's any single provider that can provide everything that an individual needs to deliver their outcomes. So I think any vibrant local community delivery model of health and social care is going to need a combination of providers with a strategic lead there. And again, if I lean on my experience in working on the housing side, it's quite a common model for actually to have that contracted in. So if the commissioner on a housing wants a a few number of large relationships, we have contracts within them that actually insist on up to 50% of the work that's carried out is commissioned by us then onto local providers. So it goes back to what outcomes you as a commissioner want. So if the development of smaller SMEs is a really important part of your overall commissioning structures, you can, through contractually, design that outcome within your commissioning approach. So I just think it's another part, goes back to what is the outcome you want as a commissioner. If the use of SMEs is important, you can design that into a model even where you've got a strategic partnership relationship. So.
I'm not going to say much more because I agree with all that, and it's a combination of all those things that happened. But I also say to commissioners, we're going to cost small providers out of the business if we don't look properly at that, because the more we screw down and all the way differently, it's not going to work. So we have to think differently in how we do that.
Any other questions? Yeah, I can see a hand waving in front of me. Thank you very much, because you are a complete silhouette.
Hi, it's Andrew from Optimus. You mentioned that, by the way, it's very bold what you're doing, it's fantastic. Very bold what you're doing, it's fantastic. You mentioned that you are not quite there yet fully, and I'm keen to just understand what is the final piece of the puzzle, the last little bit that you're trying to get right.
Well, it's not one thing. This is a huge change in culture, both in terms of the local authority and in terms of providers. So moving a whole workforce, for instance, a provider works from time and task to thinking about the person is going to take time. And it's going to take time, and it's going to take it. That's why the contracts were 7 years to try and work this through. And one of the aims, there was loads of aims in that 7 years. One was to move from 0 hours for home care workers to some proportion of the home care workforce on salary terms. It was about raising the status of home care. It was connecting with communities. This whole jigsaw in here. So the thing that I'm not there any longer, right? So the thing that it needs is constant leadership and constant commitment to this vision, and not being scared at the first hurdle, because actually the figures have stacked up. The results are showing that providers are delivering amazingly on the ongoing outcomes for people. It needs constant commitment and rigour to deliver this, because the vision is, well, in my view, the vision is right. And if we just see it as a short-term thing, like we see in so many things, or the latest thing, it's not going to work. So it's a culture change, and it's a huge culture change in the council, because it means councils letting go. Our staff now, council staff are running around saying, I've got no time, I'm doing assessment, doing reviews, I can't contract manage, I can't do anything. We've taken that all off them. So now we're saying to them, well, do safeguarding and do other things. This is your job. But it really needs constant leadership and commitment.
Any more questions? Yes, there is. Yep. Two more questions then.
I may have slightly misunderstood what you said, but I thought you said something about changing the personalisation journey and direct payments coming in later. And I noticed when you did your presentation, you looked at the first 6 weeks. But I should imagine that the approach that you're using is for the whole life of the time anyone needs care. So could you explain kind of what you mean by when direct payments kick in and how all of that works?
Well, without going into too much detail, you know, when people come in, we often in the journey of personalisation was, do you want a direct payment, or do you want us to do something? And direct payments were introduced. I was a great champion of direct payments, but not if they're used as a default for good commission services. And that's why they were introduced, because everyone thought we couldn't commission good services. And if you haven't got a market out there that direct payment people and self-funders can go to buy really good care, that really is looking after them, promoting independence, and I think as commissioners that's what we're responsible for doing. What does it mean giving someone direct payment? So what we don't do as well is give someone direct payment as soon as they come to us, because actually we want them to go through that journey of outcomes with them and with the organisations we've commissioned, because they're trained to do that, and we want to see at the end of that, the direct payment might be less, they may have a different view of what they want, and it's just a different journey. And then, we will review them as well. But it's just a totally different view of it.
Okay, there was another question there directly in front of me. Yeah. Thank you. This will be the last one, I'm afraid.
Alan, I too came from a construction background and was involved in local authority.
I can't hear that terribly well, I'm afraid.
Can't you? I too came from a construction background and was involved in local authority tendering at that stage. We used to open book tendering, processing through their shared gains with the councils, etc., etc. Is it your view that the commissioners need to be changed to bring about this, or is it just retraining, or do you need to bring in people from the construction departments into social care to make it work?
Now you're going too far. I just think that every commissioning department within a local authority has some good elements and some bad elements, and I do think that there certainly needs some best practice transfer. I think the open book bit is particularly relevant, going back to the point that you often see there seems to be for some reason a mistrust between commissioners and providers a lot of the time. And one of the elements of mistrust tends to be, are they making too much profit here? What's happening with the numbers? Are they making no profit? Are they about to go bust? Well, on our housing contracts, we operate complete transparency. So, we not only can our clients see our accounts on a monthly basis, but they have complete access to our systems. So they can see the profitability or lack of it on every single job we carry out. I always make that offer within social services, say as a part of commissioning, would you like to have access to our numbers? Up to now, nobody said yes. And I find that quite strange, because it's always quoted back to me as being a barrier for mistrusting providers. So I would love to see transparency and open book. We're a listed company after all anyway, and our accounts are available. But that you can take that down to right to the local level. And if you're worried about the financial stability, just ask the provider to make their accounts and indeed their daily costings available and see what response you get. I can guarantee you for Mears it will always be yes, because we do that all the time on our housing contracts.
Right. And I do think commissioners need to change in the NHS, in local authorities. I think we need to get more clear about, we understand our market, we understand our figures, we understand the history, we understand the trends, and we really understand what we're paying and we're buying for, and what outcomes, and we need to get outcome focused, and we need some more people who understand the figures.
I'm told there's a lady that none of us can see from up here who's had her hand up for ages, so we'll take one last question.
My name is Rosemary. I worked for Crossroads 2 years ago, and the least number of hours that we offer our services was just an hour, the least. And I'm just wondering, I've been working in residential, then I've gone back to domiciliary now. I've just found out that some of the we have services 15 minutes, 20 minutes, 30 minutes. Where did we come about those minutes? It's not good for outcome-based, is it? I'm just wondering, are we going to be able to provide, when you work with your clients, you need to have support plans and you meet them as their, aspirations and outcomes for them. But you can't do that in 20 minutes, can you? I'm just wondering, why did we come about all that? Because it's not good.
It's a good question. It's the right question to ask.
And that's the whole bit that we don't work in hours anymore. That's the whole bit about outcomes. We work on outcomes. And it doesn't mean that you're going to blow the budget by paying for outcomes if they're very clear and they're very defined. Because what we've shown is that it saves money down the line. So there's no way you can do anything in 15 minutes to someone with dignity and respect or deliver any outcome, is there? And I agree with you entirely. And that's commissioners who've got us in this place.
Conversely, actually, there are instances where in a time and task-based system, we've been commissioned to do 30 minutes, and actually Mrs. Smith we've achieved everything for Mrs. Smith within 15 minutes, and she actually wants us to go. We actually have instances where we get into trouble with the commission if we then leave after 16 minutes because we've been commissioned for 30 minutes, despite Mrs. Smith wants us to actually go. But we know if we do go, then we're going to be in a battle with somebody in administration about why that's happened, and it just gets ridiculous.
And I think we now have to stop. That was a very interesting session. Thank you both, Alan and Sue.